Picture this. A 71-year-old grandfather still gardens every morning, sits down to use the bathroom, strains, waits, and then says 7 words that change the whole picture. It feels stuck, right there, at the end. That story has a name. Here's what I'll show you today. You go to the bathroom. You feel the urge. You sit down, you push, you wait, and what happens isn't enough. Maybe a little comes out. Maybe nothing does. Maybe you wipe, stand up, and within minutes it feels like you still have to go. That heavy, blocked, unfinished feeling. Not sharp, not dramatic, just stubborn and tiring. For a lot of people over 60, this is one of the most frustrating body changes of all. Not because it's always dangerous, because it's private, embarrassing, hard to explain in one sentence. And if this sounds familiar, you're not alone. The National Institute on Aging, in material reviewed in 2022, says about 1/3 of older adults have occasional symptoms of constipation. That's a huge number. A lot of quiet suffering, in a lot of bathrooms behind a lot of closed doors. Now here's the first twist. Stool that feels stuck in the rectum may be plain constipation, but sometimes it has a more specific name, fecal impaction. That means a large, dry, hard mass of stool is sitting in the rectum, and your body is having trouble moving it out. Cleveland Clinic, in a 2022 review, describes it that way. An American family physician in 2015 says it needs to be recognized early because the plan changes once stool is impacted. Picture someone in this illustrative scenario. She's 68, a retired school teacher, still meets her walking group every Tuesday, still keeps peppermint tea on the kitchen counter. Over a few weeks, she notices she's going less, straining more, and feeling pressure low in the pelvis. Then one day she says, "I'm going, but I'm not empty." That sentence matters, because the feeling of not being empty, the feeling of blockage, the feeling that something is sitting right there, can be a clue. I'm Jason Ford. On this channel, I review published research on senior health, the kind of explanation a 15-minute appointment usually doesn't have time for. Before we go further, drop 2 things in the comments: your age and the city or state you're watching from. I read every comment on this channel, and it shapes what I cover next. Take 5 seconds. Put it below. I'll meet you there later. And stay with me, because the biggest mistake people make here is treating this like ordinary constipation, when the body may be dealing with something more specific. Let's make this simple. Your colon is the long tube that moves waste along. Your rectum is the last storage area, right before stool leaves the body. If stool sits there too long, water keeps getting pulled out of it. Day by day, it gets drier, harder, more packed together. Think of wet clay left on a table. At first it's soft, then it firms up. Leave it longer, and it stops molding well. Same basic idea. The National Institute of Diabetes and Digestive and Kidney Diseases, or NIDDK, in material reviewed in 2018, defines constipation as fewer than 3 bowel movements a week. Hard, dry, or lumpy stools, difficult or painful stools, or the feeling that not all stool has passed. That last part matters more than people realize. Not all stool has passed, that unfinished feeling. Now add age to the picture, not as the villain, but as one piece of the puzzle. As people get older, routine changes. Activity may drop. Fluid intake may drop. Appetite may change. Some medicines slow the gut. The urge to go may get ignored, because you're driving, shopping, resting, or you simply don't want to sit in a public restroom. It builds quietly. Then there's the rectum itself. If stool sits there and stretches the rectum over time, the normal go now signal can get duller. So the body becomes less efficient at sounding the alarm. You need to go, but the urge doesn't feel strong enough until the problem is bigger. But wait. This is where many people get confused. You can still pass small bits of stool and still be impacted. You can even have leakage and still be impacted. American Family Physician in 2015 points out that overflow diarrhea, Loose stool slipping around harder stool can be one of the signs. So if someone says, "I can't be backed up, I'm still passing something," that's not always the full story. And yes, this can feel strange to hear, because most people think constipation means nothing comes out. Real life is messier than that. A little may come out. Thin stool may come out. Liquid may come out. But the main mass may still be sitting there, low in the rectum, blocking a normal emptying. Now let's talk mechanics. At the exit point, your rectum and anal canal don't form a perfectly straight line all the time. There's an angle there. Muscles help hold things in and then relax to let things out. If that angle stays too closed or the muscles don't coordinate well, emptying gets harder. Think of a bent garden hose. If the hose kinks, flow slows. Straighten the bend, and flow improves. Not because the water changed, because the path changed. That's why body position can matter more than people expect. In a 2003 study published in Digestive Diseases and Sciences, researcher Dov Sikharov compared toilet posture in 28 volunteers. Squatting reduced the time needed for a feeling of satisfactory emptying, and it reduced straining compared with sitting positions. Small study, yes. But the direction makes sense, and American Family Physician in 2015 echoes the practical version of this idea, using a small footstool to help straighten the anorectal angle. That's the shareable fact in this whole video. Sometimes the first tool is not a pill. It's 6 inches off the floor. A small footstool. That surprises people, because they expect the answer to be hidden in a bottle. But the body is mechanical too. Timing matters. Position matters. Privacy matters. Muscle coordination matters. Now this next part is the one many people miss. Medicines. The National Institute on Aging, in 2022, lists several common medicine types that can contribute to constipation in older adults. That includes some antidepressants, antacids containing aluminum or calcium, antihistamines, certain pain medicines, some blood pressure medicines, diuretics, anticholinergic medicines, anticonvulsants, Parkinson's medicines, and iron supplements. So if your bowels changed after a new prescription, or after adding an over-the-counter product, that timeline matters. Don't ignore timing. And don't stop anything on your own. Talk to your own doctor or your pharmacist about whether one of your medicines may be part of the pattern. There's one more piece, the push reflex after meals. American Family Physician in 2015 recommends scheduled toileting after meals, because eating can trigger the gastrocolic reflex. That's the body's normal wave that nudges the bowels to move after food enters the stomach. In plain English, breakfast can wake up the plumbing. Use that. Because if you wait until late afternoon, after hours of ignoring the urge, after too little fluid, after too much sitting, and then you rush the process, you're working against your own body. Here's the deeper issue. Stool stuck in the rectum is not always just about stool. Sometimes it's about coordination. The pelvic floor, the group of muscles that supports the bladder, bowel, and other organs, has to relax in the right way at the right time. If those muscles tighten instead of releasing, you can strain hard and still feel blocked. Push against a closed door and nothing good happens. That's why some people say, "I'm trying harder than ever and less is happening." The problem may not be effort. The problem may be the system. And this is where the video turns. Because once you understand that hard stool, body position, medicine effects, timing, and muscle coordination can all be part of the same bathroom problem, you stop blaming yourself. You stop saying, "I'm lazy," or "I'm failing," or "This is just old age." No. This is a body process. And body processes can be understood, which means they can often be improved. So what do? Let me give you 5 steps, and I'm going to put them in the order that helps most people think clearly. Number 3 surprises people, and number 1 is the one almost nobody talks about the right way. Step 1. Figure out whether this is constipation, fecal impaction, or both. That sounds obvious, but it changes everything. If stool is impacted in the rectum, The plan is not the same as a mild slowdown from travel, a low-fiber week, or one skipped bowel movement. Cleveland Clinic in 2022 describes fecal impaction as hard stool stuck in the rectum. American Family Physician in 2015 says any fecal impaction should be treated first. So what do you ask your doctor? You ask, could this be impaction, not just constipation? You ask, does my pattern sound like stool is sitting low in the rectum? You ask, do I need an exam to tell the difference? That matters, because guessing can waste days. And if you're having pain, rectal pressure, stool leakage, nausea, or repeated straining with a strong blocked feeling, say those exact words. They help paint the picture. Step 2. Use timing and position to work with your body, not against it. This is the one many people dismiss until it helps. Try using the bathroom after a meal, especially breakfast, when the gastrocolic reflex is strongest. Give yourself enough time. Don't rush. Don't perch. Don't hover in a half-sit. And if it's safe for your balance, use a small footstool so your knees are a bit higher than your hips. Not dramatic. Helpful. American Family Physician in 2015 recommends scheduled toileting after meals and placing the feet on a small stool. And that 2003 Digestive Diseases and Sciences study showed that posture changed both straining and the time to a feeling of satisfactory emptying. Now, I want to be careful here. If you have balance trouble, recent surgery, severe hip pain, or a fall risk, talk to your own doctor before changing bathroom setup. Safety first. Always. But for many people, this is the start. Not because it fixes everything, because it removes resistance. Here's another part people miss. Privacy matters. Time matters. Long-term care settings, busy homes, shared bathrooms, and bedpans can all make emptying harder. The 2015 American Family Physician article notes that patients should be given time and privacy and should avoid defecating on bedpans when possible. The body does not love being rushed or watched. That's human, not weakness. Step 3. Build softer stool slowly and in a way your doctor agrees with. This is where people often swing too hard. They hear fiber, then load up on it overnight. Brand cereal, fiber bars, powders, prunes, all at once. Then comes bloating, cramping, and disappointment. And they say, see, fiber makes me worse. Sometimes it can, if the stool is already sitting there, dry and stuck, and you pile more bulk behind it. That's why context matters. American Family Physician in 2015 recommends about 20 to 35 grams of fiber a day, introduced slowly. The National Institute on Aging in 2022 also recommends more natural fiber from fruits, vegetables, and whole grains, along with enough fluids to help stool stay easier to pass. Slowly is the key word. If you think fiber may help you, ask your doctor or dietitian what type makes sense for your situation and how slowly to add it. And if you have heart failure, kidney disease, or another reason you've been told to limit fluids, ask your doctor what drink more means for you. Your plan should fit your body, not a slogan. Now this next one is the one everyone misses. Medicine review. Step 4. Review every prescription, every supplement, and every harmless over-the-counter product. Not some of them, all of them. Bring a full list. Or better, bring the bottles. The National Institute on Aging in 2022 says constipation in older adults can be linked to some antidepressants, some antihistamines, antacids with calcium or aluminum, certain pain medicines, diuretics, anticholinergic medicines, anticonvulsants, Parkinson's medicines, and iron supplements. That list is longer than people expect. Here's an illustrative scenario that comes up often. A 74-year-old retired mechanic starts taking iron, a sleep aid, and a stronger pain medicine over the same month. Then his bowels slow down. He thinks, I need more roughage. Maybe. But the more important question is, did my medicine list change the plumbing? That's the question. Ask your doctor or your pharmacist. Could one of my medicines be causing or worsening this? Ask, is there a safer alternative for someone my age? Ask, if I need this medicine, what bowel plan should go with it? That last one matters more than most people realize. Sometimes the right answer is not stopping the medicine. It's building a prevention plan around it. And please don't stop a prescribed medicine on your own because of a video. Talk to your own doctor. Step 5. If stool may already be impacted, ask about a doctor-guided treatment plan, not random trial and error. This is the part where people get nervous, because it sounds bigger than it is. But calm matters here. American Family Physician in 2015 says fecal impaction should be treated first, with mineral oil or warm water enemas, or manual disimpaction. Cleveland Clinic in 2022 also describes enema treatment and physical removal in some cases. The key point is not that everyone needs the same thing. The key point is that the treatment depends on what's really going on. That's why guessing at home can backfire. If stool is impacted low in the rectum, your doctor may suggest a specific plan. If constipation is more generalized, the plan may be different. If muscle coordination is the issue, the answer may involve pelvic floor treatment or biofeedback, not just laxatives. Different cause, different fix. And there's one safety detail worth remembering because it's not widely known. American Family Physician in 2015 warns that sodium phosphate enemas should be avoided in older adults because of serious electrolyte risks. That's one of those facts families repeat to each other once they hear it. Not every product on a pharmacy shelf is a good idea after 60. So ask your doctor, if I need rectal treatment, which product is safest for me? Ask, do I need an exam before trying anything else? Ask, would an osmotic laxative like polyethylene glycol fit my situation? Or is something else better? And yes, polyethylene glycol, often called PEG, is commonly used in stepwise constipation care. The 2015 American Family Physician article places osmotic laxatives early in treatment after lifestyle steps if needed. But dosing, timing, and fit should come from your own clinician, especially if you have kidney issues, heart issues, swallowing problems, or a complicated medicine list. Now, here's where most people get it wrong. They look for the one magic answer: the bathroom posture, the prune juice, the laxative, the fiber cereal, the colon cleanse. One trick, one fix. Most of the time, that's not how this works. The better frame is this. You're trying to improve the whole path: softer stool, better timing, better position, fewer constipating medicines when possible, and the right level of medical help if stool may already be stuck. That's a system, not a gimmick. If this part of the video is useful, hit subscribe. I do one of these every week, and I try to give you the part that gets skipped in short office visits. Now let's add one more layer. Movement. The National Institute on Aging in 2022 recommends staying active, even simple walking, because inactivity can contribute to constipation. This does not mean you need a perfect exercise plan. It means the gut likes motion. The bowels like routine. Your whole system likes rhythm. So if your doctor says walking is safe for you, ask whether a short walk after meals could be part of your plan. Not punishment, rhythm. And here's your second comment prompt, because I'm curious what this audience sees in real life. What changed first for you? Harder stool? Less frequent stool? More straining? Or that unfinished feeling? Put just one phrase in the comments. I read those patterns closely. There's one more hidden step, and this may be the most reassuring part of the whole video. If you've been straining hard and still feel blocked, that does not prove you need to push harder. Sometimes it proves the opposite. Sometimes the body needs less force and better coordination. Talk to your doctor if you think pelvic floor problems may be part of this. Especially if you feel the urge, sit down, push, and feel the muscles clench instead of release. That story is more common than people think. And if you have a parent, or a spouse, or a friend this applies to, this is worth 60 seconds of their time. Send it to them, because a lot of people are not dealing with just constipation. They're dealing with a system that got out of sync, and no one ever explained the parts. Now, I want to answer the question I know may be in your head. If I'm still going every day, how could stool be stuck in the rectum? Here's the honest answer, because frequency is only one part of the picture. You can go daily and still not empty well. You can pass small pieces and still have harder stool sitting behind them. You can even leak loose stool around an impaction. American Family Physician in 2015 points that out clearly. The real question is not only, how often am I going? It's, am I emptying well? That's the better question. Let me name the sources one more time, because you deserve to know where this comes from. The National Institute on Aging, reviewed 2022, explains symptoms, medicine triggers, lifestyle steps, and when to get checked. NIDDK, reviewed 2018, defines constipation in plain clinical terms. Cleveland Clinic, reviewed 2022, explains what fecal impaction is and how it may be treated. American Family Physician in 2015 lays out practical management in older adults, including footstool use, scheduled toileting, and treatment first thinking when impaction is present. And the 2003 Digestive Diseases and Sciences Posture Study gives us that memorable toilet angle insight. That's not internet folklore. That's the difference. Now for the limits, because this matters just as much as the solutions. There are situations where you should call your doctor today. Not next week, today. If there is blood in your stool or bleeding from the rectum, if you have serious stomach pain or you cannot pass gas, if you're vomiting or you have a fever, if you're losing weight without trying, if your bowel habits changed and fiber, fluids, movement, and routine changes are not helping. Those red flags line up with guidance from the National Institute on Aging in 2022 and NIDDK in 2018. And they are outside the reach of a general video. They need direct evaluation. One more thing. If you've been relying on repeated straining, please talk to your doctor about the pattern itself. Long, repeated straining is not a badge of effort, it's information. It tells you the system may need a different plan. Let me run through the core points quickly. If stool feels stuck in the rectum, the issue may be more than ordinary constipation. Fecal impaction means hard stool is sitting low, and the body is struggling to move it out. Position, timing, fiber, fluids, medicine review, and doctor-guided treatment all matter. And the goal is not force. The goal is better function. Here's the whole message in one sentence. If you feel blocked, unfinished, or like stool is sitting right at the end, don't brush it off as just age. Ask whether your body is dealing with stool that has become too hard, too dry, too delayed, or too mechanically difficult to pass. If this helped you see something new, subscribe. Next week, I'm walking through 3 common medicines after 60 that can quietly change your bowels, your sleep, and your balance, and why people often blame aging for all 3. And in the comments, I'd love to hear this. What part of today's video surprised you most? But there's one thing I still haven't told you, and it's part of why that next video matters so much. Sometimes the problem is not the food on your plate, it's the label on the bottle. Take good care of yourselves. I'll see you next week. This video is for general educational and informational purposes only. It is not medical advice and does not create a doctor-patient relationship. Please always consult your own qualified healthcare provider for diagnosis and treatment. Illustrative scenarios in this video are composites. All identifying details have been changed to protect privacy. Any resemblance to a specific individual is unintentional. Portions of this video use AI-assisted voiceover and visuals.